looking at COPD and we're asking ourselves, what is COPD, right? So COPD is where there's obstruction in the airflow into and out of the lungs. So both in and out, right? And it's irreversible damage to the alveoli. So we kind of mentioned that before, right? We said there's a problem with trapped air inside the lungs. The person breathes in and it's hard to breathe out, so it gets stuck inside there. That's why we mentioned that there's going to be high what? If they're high acid, right? Respiratory acidosis. Okay, so it's a progressive airflow limitation. And the reason why it's progressive, I had mentioned the difference between asthma and COPD. What happens after an asthma exacerbation? It can revert back, right, to the way it originally was, and they can feel better. But what happens with a COPD person that is exacerbated? They develop more of an issue. So then once they get to a certain stage, do they go back? No, that's the irreversible part, right? Once it gets bad and there's an exacerbation and they end up in the hospital and they maybe some more damage happens, they can't go back to the original state, right? And so what's causing that? It's the inflammation. So the inflammation response occurs throughout the proximal and peripheral airway, right? And so we mentioned inflammation is good, but too much inflammation is bad. Too often is bad. Lasting too long is bad, right? Inflammation is a great response for the body to heal itself. It brings white blood cells, red blood cells, platelets to the area to heal whatever damage it feels that is happening or whatever bacteria it wants to fight. But if it happens too much, there's going to be damage there because there's going to be distortion. The cells are going to be shifting and expanding to accommodate all the blood flow, right? And that's not a good thing. So constantly, if that's happening, eventually the lining of that area where the inflammation is happening, wherever it is, it's going to eventually feel that effect. We're going to see when you get to quarter 5 or 4, when they talk about heart failure specifically, that's the biggest problem. When those arteries and those blood vessels and those valves are expanding and causing damage there, inflammation happens and it deteriorates it and it causes something called remodeling. That body does that, right? It tries to accommodate to whatever the effect is. And it happens because of the inflammation process, right? And so once there's remodeling, the body or the heart is not going to function the same way. Everything's the same way. The lungs are the same. Because there's going to be inflammation in the alveoli, there's going to be some kind of remodeling, reshaping to accommodate to the fluid that's filling it, the blood cells that are trying to help. Eventually, it's going to damage it. It's going to stretch it out, and it's not going to work as well as it used to because it needed that structure for a reason. Okay. All right. So here's a picture. Right? This is a normal lung, how it's supposed to look. Clear, open enough for the alveoli to receive the oxygen the way it's supposed to. Blood diffuses into the different areas. But here, when we have it's too big, it's way too big, right? Because the elasticity, it has broken down and it's not expanding. Well, it expands okay, but it's not contracting. It's not closing up the way it's supposed to. And we had mentioned that it's doing that kind of like a balloon, right? When a balloon expands, right? After a time of having been expanded constantly, when you hold it up, you see it's kind of more lax than if you hold up a brand new balloon. The brand new balloon looks a little more taut. It's kind of the same idea when you think about it. And it doesn't have the same stretch. And since it doesn't have the same stretch, it doesn't have the same abilities as it did before. And we also have the overproduction of the mucus, right? Up top, you see that. We mentioned anytime there's an irritant or a problem, the lungs has its way to try to accommodate. Okay, so there's a lot of pollutants, there's a lot of irritants here, smoking. So we're gonna increase the production of the mucus so that we can clear it out much more easily. But then it's not really meant for all of that mucus. It becomes a problem. Okay. So then we also can develop other problems too when we have COPD, which are even worse. We can have the pulmonary insufficiency, which talks about how we don't have enough oxygen to do the job, and so it switches, and now it's like, okay, since I don't have enough oxygen, I'm gonna change so I can make COPD my thing that I prefer, and so it switches. And then we also have the pulmonary hypertension, and the way pulmonary hypertension works is when you think about these alveoli, right? They connect to one another. The blood flow from here goes into this one, and then that one, it's all connected. So if something happens, like you see this picture, and the cells are not working properly, if this alveoli is damaged, it's not going to receive the blood that it's supposed to because it's collapsing, it's not working, it's not functioning. The body realizes that. It's like, why would I waste my precious, vital, energy-giving, life-giving blood here if it's not going to work properly? So let's shunt it. Let's send it here because this place still works. But unfortunately, this really it was not built to accommodate twice the blood that it was supposed to accommodate. And so it builds pressure here. But then we think about, where's all of this blood coming from? Eventually, it's going to start affecting the heart, right? Because when we get to the heart, we think about the structure. The heart sends the blood to the lungs to get the oxygen. So if the blood is not being diversified or sent to all the little alveoli, and it's this one, like the top here is shut down, this door is shut, this room is shut, then it's going to keep it here, and that pressure is going to back up to the heart, right? And then we have what's called pulmonary hypertension, right? And that's not a very good thing. When we learn how, okay, so for the heart to pump to the body, it's a longer route, so it needs more pressure. So its pressure is like maybe 60, right? But for it to send it to the lungs, because it's a short distance, it's only like 30, right? But now that there's a backup, the pressure increases, and that can damage some cells, right? And so that's a problem. And then we have cor pulmonale. Now, cor pulmonale, so the pulmonary hypertension is just when the blood pressure of the lungs increase in and of itself, and the lungs do not like that, and we can have damage. But that resides in the lungs itself. But once we have cor pulmonale, that's when that pressure starts now to affect the heart. Once it starts backing up, and now the heart becomes affected, and it's now getting damages to it, that is called cor pulmonale. So that's when we have heart failure, heart problems, because the lungs have the hypertension, right? So when we have regular heart failure because the heart is not working, we call that heart failure. But when we have heart problems because the lungs are not working properly, we call that cor pulmonale. You see that? They just give it a different name to identify where the source of the problem is coming from. If it's an artery issue, it's heart failure. If it's a lung issue, it's cor pulmonale. Okay, so obviously we always say, right, these are the complications. These are the things we're looking out that we don't want to happen. Anything that we're doing it in order to prevent this, okay? So we have, okay, there are two types of COPD, right? We have the emphysema and we have the chronic bronchitis. Do you guys remember from your reading any, like, the differences that you might have noticed as you were preparing? So the biggest difference really is what structure is being destroyed. And so emphysema, it's mostly the elasticity, right? It doesn't expand as well. It's like the paper bag that we mentioned last class. The air gets into it, but the elasticity is broken down, and so then it doesn't retract the same way that it should. Usually I take a deep breath and I let it out, and naturally the lungs collapse on their own. But with COPD, because the elasticity is not very good, it doesn't retract. It doesn't collapse on its own. So it's like that paper bag, right? With bronchitis, the biggest problem is the mucus production, right? Because of the irritants, the body produces more mucus than it should. And so we're going to see, like, those people are the ones with that chronic cough that, you know, is like constant, and they look like they have been having colds too often, right? And so the emphysema is more with the elasticity and not being able to get rid of the carbon dioxide that's inside the body, and the bronchitis, same thing with the COPD issue, but it's because the the mucus buildup is blocking the airway, right? So let's talk a little bit more about the differences. So we have here chronic bronchitis. So we have the little symbol here where it say they're blue bloaters, right? So that mucus is trapping the carbon dioxide inside, and they're turning blue. So airway flow problems, they have this color dusky to cyanosis, a recurrent cough, that's the big thing, increased sputum production, hypoxia, hypercapnia, respiratory acidosis, increased hemoglobin. The increased hemoglobin, do you think, why would that happen? It's trying to get more oxygen, for sure, right? Because oxygen travels on the hemoglobin. There's an increased heart rate. So these are the signs, right? Exertional dyspnea, increased incidence in smokers. So this happens a lot in smokers. Digital clubbing. So for the clubbing, I always say, right? So in the extremities, right? It's like the body is seeking oxygen, so it's expanding to look for oxygen. But it happens in chronic. We saw that in our last question that we just did. Okay, so we'll have cardiac enlargement, right? Use of accessory muscles to breathe, and it leads to right-sided heart failure, bilateral pedal edema, increased JVD. So the right-sided, when you get to quarter 4 again, you'll learn more about heart failure. So you can have right side, you can have left side. And so the right side one is the one that says it goes back to the body, right? So there's a problem with the lungs that's causing it to go back where it came from. Since it came from the heart, it's going to go back to the heart, and the heart is going to be damaged. But then once it hits the heart, it got to go back from where it came from too. And where did it come from to enter the heart? It entered from the superior vena cava, inferior vena cava, which had collected it from the upper extremities, the head, from the jugular vein, lower extremities, legs, organs, all of those. So we're going to have splenomegaly, we're going to have edema, right? So all of this is happening because the lungs are not working properly. So the blood is going to back up to where it came from, and it came from the lungs, the heart, right? The right side of the heart, right? So that's the problem there with the right-sided heart failure, the pedal edema, and the JVD that we're going to see. So all of that was chronic bronchitis. Let's see if I missed